All right, so we're going to go ahead and get started here. I want to introduce our next speakers, Lori Galioto, who is with our Compass Practice Transformation Network here at IHC. She received her bachelor's degree from Creighton University in Omaha and recently completed her graduate degree in nursing with a clinical nurse leader focus at Grandview University in Des Moines. Lori has experience working in the inpatient, outpatient, and clinic settings. Prior to accepting her position here at IHC, she worked as a health coach with the Mercy Accountable Care Organization in Des Moines. We also have Kathy Kunathof, who joined the Iowa Chronic Care Consortium in 2004 to assist the consortium in applying for national grant opportunities in chronic care management and to support their ongoing demonstrations in chronic disease management. In 2008, she served as the lead project facilitator of the innovative Physician Office Health Coach Training Program. She's maintained the coordination and expansion of this program to the current Clinical Health Coach Training Program. Kathy also continues to serve as consultant and facilitator in operationalizing chronic disease management programs with a variety of hospitals and healthcare organizations. Kunathof has a personal mission of building healthier communities by serving as a catalyst for growth in both individuals and organizations. And then also during this presentation, we will hear from Joan Parker, who is the ambulatory clinic coordinator and health coach for Cornerstone Family Practice, which is a department of Gutenberg Municipal Hospital. Joan has been the ambulatory clinic coordinator since 2012 and is a certified health coach since 2015. Cornerstone Clinic was formerly named Family Medicine Associates, and Joan has been working there since 1998. So I am going to go ahead and turn this over to Kathy and Lori.
Well, hello everybody and welcome, and thank you for joining us today. I hope you're enjoying your morning at the HIN virtual learning community. I know there's been a few bumps in the road, but I'm glad you're all hanging in there and able to spend time with us today. My name is Lori Galioto. I will be starting our session off today. Sorry, I'm getting all the buttons down here. Just trying to advance my slides. Just hang on one moment. Oh, there we go. So I'll be starting off today, and then Kathy and I are going to be tag teaming the first part of our webinar today, and we'll be hitting those first 4 objectives, and then we're going to save the best for last, and we're going to let Joan speak about how they have used strategies within their clinic to successfully connect the dots across their medical neighborhood. So I'd like to begin by discussing the role of the medical neighborhood. This first slide reflects what many would consider to be a patient-centered medical neighborhood. You will see that there are components of the medical neighborhood represented. For example, you have the hospital and acute care, you have pharmacists, you have community and social services, and you have the patient right there in the middle of the neighborhood. So that looks great, doesn't it? The problem with this scenario, and a problem that's very common in the real world, is that the patient is left there in the middle of the neighborhood to navigate all the entities on their own. So the members of this neighborhood appear to be in close proximity. They might even be part of the same health system, but there is actual minimal communication or coordination between each entity. So while the patient assumes that this system is coherent and organized and that they're helping to coordinate care, that is not necessarily how it works, and the patient is left as the main conduit of information between the providers. So one approach to address this fragmentation and to improve the coordination of care while also addressing what the needs of the patient is the implementation of the patient-centered medical home. So most of you, I'm sure, have heard this term. It's also called the PCMH. And what it really is, the PCMH is a model for transforming how healthcare is organized and how it is delivered. The PCMH transformation most often takes place in the primary care provider's office, and this provider and his or her care team becomes the central point of contact for the patient and is the hub of where the primary coordination of care takes place within the medical neighborhood. So the PCMH, in partnership with the patient, becomes the center of the medical neighborhood. I want to emphasize this, that the primary care provider and his team are taking responsibility for the patient as they travel through the different entities. So if in the past you have had problems engaging the primary care providers in partnering with you, you may find that they are more open to this now and may have team members in the office who can be points of contact for communicating important information, because they are now more responsible for health outcomes, they are more responsible for reducing unnecessary hospitalizations, and their reimbursement is dependent on it. So the patient-centered medical home really can't do its job unless it's in a mature medical neighborhood. And I just have this slide to highlight what the 6 attributes of a mature medical neighborhood is. The first one is a clear agreement or delineation of roles. So if you're talking between the clinic and the hospital, you want to know who is responsible for instance, when a patient's admitted, you want to make sure that the clinic is giving you the information that you need. When the patient's going home, you need a clear agreement of when you will let the provider know that the patient's been in the hospital and how to get that information of what happened in the hospital back to the provider, which goes into number 2 there, the sharing of clinical information. Hopefully you have an IT system or an electronic health record that can help you with that. If not, you just need to come up with some sort of process to communicate. And then ideally there would be individual care plans that the patient carries around with them electronically through the medical neighborhood, so that through their care transitions, they continue to follow the same plan of care. And then, of course, we need continuity of care, good coordination of care. We must focus on the patient's preferences, and then make sure that we understand where those strong community linkages are so that we can offer the patients all the services that they need. So, some takeaways from my little blurb there about medical neighborhoods is that we're all working in this together. We're coordinating care together. In the medical neighborhood, we're all accountable and being paid for improved patient outcomes. And we've all got to figure out how we're going to work together. So on that note, I'm going to hand the microphone over to Kathy, and she's going to talk about team-based care.
Good morning, everybody, and thanks, Lori. And I'm just really pleased to be here and joining in on a team-based conversation around medical neighborhood, around coordinating care, and really the role of the health coach. Because some of you who are on the call may or may not have a relationship with perhaps a health coach who may be in the primary care setting, although there are coaches that are in a variety of different settings, and some of you, this may be new information. So what I want to start with is the idea that the bigger picture around this is team-based care. And team-based care means that there could be a variety of healthcare professionals in playing different roles as that sets up in your particular organization. In just a few minutes, we're going to hear from Joan and how that team-based care looks for her organization. But for each of you, there isn't one kind of a national standard about what team-based care looks like. So we do recognize that your team is kind of who's there for you to be able to have this communication and this care coordination with. But there is kind of a standard definition, and that being is that team-based care is when we provide healthcare services to individuals and families, but there have to be at least 2 healthcare providers who are working collaboratively with the patient and their caregiver. In other words, they've got to be communicating back and forth between providers and collaboratively with the patient and their caregiver. And this is a real key piece for coaching to the extent preferred by each patient. So we are increasingly recognizing that patients, even though while they're in our setting, may be agreeing to treatment plans or medications, that the reality is that when they leave and they go home, they're going to make decisions on their own. So the quicker we can learn their preferences and what they're willing and what they're able to do, that's really important in the care. And the goal is to accomplish shared goals, not just ours as providers, but also theirs in their health futures, within and across settings to achieve coordinated high-quality care. That's a great big long sentence, and each piece of that has its own almost day-long conversation, but it does bring all the pieces of team-based care together. So why is it so important to build teams? In today's environment, for one thing, any one provider cannot keep track of all the different best practices. Currently 2,000 clinical best practice guidelines out there and growing. And so different eyes on different guidelines are very important to bring into the team. We know there's a primary care provider shortage, so we really have to increase who is on the team and who can provide the care that can be comprehensive between care members. And we also know that, there may be increasing referrals to specialists, but specialists need still to bring that communication back to the primary care provider. As Lori mentioned, the primary care provider is the navigator of the sort of holistic health of the patient. Another reason is because chronic disease management is complicated and complex, and the typical Medicare beneficiary visits a minimum of 2 primary care clinicians and 5 specialists per year, and you can imagine how confusing that gets. Potentially, if we don't coordinate and communicate between teams, harmful things happen, and I know that we're tracking measures around a lot of those potential challenges. But the more we communicate and the more we share what's going on with medications between providers and with patients and other issues, the better. And also interprofessional care. We know that each team member brings something special to the team care. And so we may have, pharmacy who has their specialty. We may have registered dietitians, social workers, and the more that we can build that team, the better the care for the patient. But we recognize it's still evolving, and there are a lot of innovative models and programs out there. Lori talked about the patient-centered medical home. There are also care transitions teams, and I think that Sarah talked a little bit about that this morning in terms of that call out to patients when you are doing medication reconciliation, but you're also looking at other care transition kind of needs and making sure that the patient really understands when they're discharged from one setting to another, kind of, where does that path go? Also, new growth in business organizations that are healthcare accountable care organizations, and there are a variety of community-based care teams that we can refer to when patients are discharged or they're, self-managing their chronic condition. So this slide just gives an example of the kinds of models that are out there, and this is a little bit of a dated slide. So some of these models have grown, some of them may have fallen off the map, and there are new ones, but there are always new experiments, if you will, and that's a little bit around some of the work of PCPI and some of the great innovation that's coming out of CMS is to encourage us in team-based care to build effective models of care. We know that the most expensive part of healthcare today is chronic care management. And so this particular model is probably something that you've seen over and over. And it is a comprehensive model. We know that there's care happening, in the health system and out in the community. But the part that I want to talk about here is that interaction between teams, between the informed and activated patient and the prepared and proactive practice team. And a lot of times a health coach can be kind of the central force of that productive interaction and team-based care. So I want to just briefly run through just a couple of examples of what teams look like, because again, in your setting, they could be different than another setting, but a lot of times in the primary care team, it's the physician, perhaps if they're lucky, an advanced practice clinician, perhaps medical assistants, nurses, lab techs. Health coach is obviously highlighted there because that's what we want to spend a little time on today, but sometimes they're not called coaches. Sometimes they're called care coordinators or care managers on the primary care side. And if you get really lucky, the additional team members really add value to patient care, and those are listed on the right. In the hospital side, where most of you are, we still have teams, but they look a little bit different in the roles that they play. Again, you may see coaches in the hospital, and a lot of the times that work is looking at reducing readmission. So you may have a formal care transition plan, and you may have outpatient programs where you're referring to cardiac and pulmonary rehab, diabetes education, and perhaps clinics, heart failure clinics, anticoagulation clinics. And the more that we have these services to refer to, the more supportive the patient can be. And then out in the community, there are our community care teams. These are just examples. In your own community, I would just say and encourage you to go out and take a walk and look at where all these people are and all these clinics are. And maybe if you haven't, build a resource directory of where these services can be in your medical neighborhood. All right, so when we start moving into health coaching, it's just that is a part of the team-based care process, and coaches certainly fit within team-based care very well. And the work that they do is in support of population health management, activating patients, and I know that was a measure that a lot of us are following. Patient activation, patient family engagement, coaches can be very supportive in that, and also care management and care coordination. So with that, I'm going to turn it back to Lori to talk a little bit more about population health, because that's, again, a very important part of today's healthcare and keeping populations healthy, and coaches can be very effective in that process.
Okay, so thank you, Kathy. And I'm going to talk about population health, but I'm really also going to pull this into how the team works together to accomplish population health. So this is just a very simple, brief description of what population health is. It refers to the approach of providing evidence-based interventions to a defined group of patients with similar needs in order to improve their health outcomes. So a high-functioning medical neighborhood will be able to incorporate population health strategies really across the continuum. And actually, Joan is going to have a great example of this when she talks about the strategies that they've used at Guttenberg. But to accomplish this daunting task, it's important for the caregivers within the neighborhood to really understand their patient population. If you can have a multidisciplinary team coming to the table to really dig into this information, that is very helpful. But this slide gives some examples of ways to learn more about your population. So it is very important to understand the common diagnoses that you have within the neighborhood, how many patients have multiple comorbidities that are putting them at higher risk, and are there common groupings of those comorbidities. Because as you're going through and looking at the patient population, you are trying to strategize what evidence-based practices you can put in place to help them be better. So perhaps you have a lot of asthma patients, but you're finding that they're still smoking. So you have a couple different strategies that you can use to address that population. You can also look at utilization. Do you have patients who are going to multiple different specialties? Are they going to the ER a lot or the urgent care? What are the average number of medications that patients who are being seen in the hospital or the ER, how many are they taking? And that's something that you can pull your pharmacist in to help come up with good ideas of how to address medication management. Social determinants of health, you're all aware that's huge. So if your population tends to have problems getting to the doctor, or if there's a language barrier, then your multidisciplinary team can come up with strategies to address those. Health literacy is another big one. Have you actually used tools to determine what the health literacy of your patient population is? And do you have different ways to address different levels of health literacy? For example, if someone with a low health literacy, I'm going to talk from the clinic standpoint, perhaps that health coach, if they know that the patient is having a change in medication, they will call the patient the next day. Or if they need to learn how to do insulin, instead of just showing them in the office and sending them home, maybe a home health nurse needs to go out and work with that patient. So there are all different ways that you can address caring for your patient population. And this just, again, sort of talks about, excuse me, populations at risk and the best ways to manage them. So the populations at highest risk, and it says here who have filed a claim, so somebody who's been to the ER or in the hospital, they need close disease management and care management. And those are the ones that are going to be drawn to your attention. That's why they are, that's part of the iceberg above the water. And that's the ones that the hospital and the clinics are going to be bumping into together. Then you have your rising risk population. So they, you know that they are at risk, but they're not really sick yet. They're not ending up in the ER. And that is a great time to be able to intervene and prevent them from getting, becoming higher utilizers. And then you have the bottom, which the population is pretty healthy, and we really need to focus on health maintenance and promotion. So these are just a few opportunities for collaboration between the patient-centered medical neighborhood. And that is that you have health management goals that everyone is aware of, that the caregivers are included in any education and care coordination. So we can't forget how important they are in helping their loved one to be successful in their self-management goals. We need routine reporting feedback loops, so good communication between the patients, the healthcare plan even, any ancillary providers. We need a way to address care gaps, and that includes, like we talked about, the health literacy and health disparities, and then ongoing evaluation of health outcomes. So the team needs to get together and make sure that the interventions that they're putting in place are actually improving the overall population health. And then these are just a few statistics. So 86% of healthcare dollars are spent on chronic illness. 75% of these dollars are spent on high cost and often preventable services. So that's your unnecessary hospitalizations, ED visits. And then the cost of care for patients with comorbid conditions is 7 times more than the cost of treating patients with only one chronic condition. And then we get to that final one, that 96% of care is self-care, and that's when I'm going to lead back into Kathy talking about the health coach and her role and how she works with patients to activate their self-management skills.
All right, thanks, Lori. So hopefully we've created a good picture so far of the medical neighborhood and the need to be communicating back and forth in different settings within and throughout these settings, and including the patient, that this is team-based care, and that there may be different providers communicating the care needs, and that we are kind of, the goal is to raise the health of an entire population that we serve. Back in the slide that talked about the accountable care organizations, you know, the goal of, and I know that a lot of you that are on the call probably are part of an ACO, and the goal of that ACO is really to keep the entire population of patients as healthy as possible. And most of the time that is through the less expensive services of, say, provider, you know, primary care providers, of actually coaching. And I know there's a lot of questions about, can you bill for these kinds of services? And the answer is, for some populations, yes. But we're kind of getting away from the idea that it's all about billing. It's really about reaching out to populations and keeping them healthy, and overall avoiding high-cost, expensive hospitalizations and ED visits. So the concept of the clinical health coach or clinical health coaching is to keep an eye out on that population of patients that, when Lori showed you the risk iceberg, it could be the people above the risk line, or it could even be people right in that rising list, but they're team members working closely with the physician lead in either the patient-centered medical home or in any clinical healthcare setting. But basically, they are not only just seeing the patients that come in for the day for, you know, whatever reason brought them in, like an acute care need, but they're actually going to be reaching out to these high-risk populations and spending a lot of time in coaching and working them and helping them with the self-management support. Again, they could be a care manager, a care coordinator, a coach, a health navigator. There are so many names for this position. that I just want to assure you that it does not have to be called a health coach, but the role tends to be the same. The goal is to engage and partner with patients, and this is in bold, to improve their health behaviors, build their self-care skills, and inspire their personal accountability. Again, it gets back to the idea that patients are in our setting for, in their minds, probably as short a time as possible, and they make decisions on a daily basis on what they're going to do in terms of their self-management. So we really want to work with them in as positive way as we can to build their self-care skills. And the focus is truly on behavior change of the patient. So if patients, for instance, that has a chronic condition, if they can nod their head and say that they understand what they should do from a treatment perspective or how they should do self-management, but if they don't make any behavior changes, then there won't be a change in health outcomes for them. And that's what we're really about at the bottom of the pyramid. The basic thing is helping patients to self-manage in positive ways. So this slide just goes into the fact that, sadly, the way we've been trying to address this isn't working very well. And some of these statistics are really older statistics, but they haven't changed much over the years. As an example, 40 to 80% of medical information that patients receive is forgotten immediately. So back to Lori's conversation about health literacy, sometimes that's because of perhaps a cultural or a language or reading level, but a lot of times it's just due to the fact that healthcare in general is very stressful and patients just can't remember the information we give them. 30 to 50% of patients leave their provider visits without understanding their treatment plan. And again, they're most likely going to tell that provider that they do understand it because they want to please. They want to say, yep, I got it. I'm going to go home. I know exactly what I should do. And so many of them actually don't know what to do. So those phone calls, those follow-up calls are really important. Half the information that they retain is incorrect. So there's a little bit of reconnecting and making sure that everybody's on the right track. And hospitalized patients, we know, do not retain, in fact, they only retain 10% at most of their discharge teaching. So that's probably why a lot of times we are going away from that standard discharge teaching and doing the follow-up phone calls and perhaps referring them back to primary care just as quickly as possible so that they can, get back into more of a comfortable type of healthcare versus being still frightened by being in the hospital and not feeling very well from being in the hospital. 20 to 30% don't fill their prescriptions, and 50% of meds are not taken as prescribed, which is the main reason why you have med reconciliation and you have conversations around medications. And do be aware that sometimes people don't take their medications because they just don't want to take them for a number of reasons. So that's a good conversation for a coach to have and get to some level of, just honesty and transparency. And it's better for a patient to say, I'm not going to take that medication rather than us assuming that they are and find out they're really not taking those medicines, which could be a harmful outcome for them. So what is the role of the coach? As you look at this list, you'll see some different descriptions that may not be your standard care coordinator, nurse job description, but the idea of partnering with patients and collaborating and facilitating. And what that comes down to is getting to know the patient and using skills, health coaching skills, which are not intuitive, by the way, to most of, at least I'm a nurse, and it wasn't intuitive to me, and that's what we hear a lot, is that this is kind of like speaking a new language and requires some time and effort and training in order to learn these skills. But what you're doing is kind of taking off your expert hat oftentimes and really working with the patient to understand where they are in their lives and what they're willing to follow through, and then being able to collaborate and facilitate referrals that they're willing to go to. We explore and provide resources as coaches. Again, that's kind of looking at the rest of our medical neighbors. Who do we have that we can refer and do a warm handoff to? Supporting self-empowerment and giving patients confidence that they are the experts in their own healthcare and that we see them as capable. That is a huge concept, and that we aren't creating dependency, which is something that I used to work in cardiac rehab, and I always wanted them to be there the maximum of 36 sessions, but in some cases that was actually creating dependency. And then, as Lori mentioned, you know, we're looking at a population health process, and we want to guide that process. Coaches can reach out to those patients that need services the most. So the role ends up looking a little bit like a quarterback. They can be very strategic in terms of figuring out what is the best plan for any given patient. Or they can look at a database and figure out which patients need that follow-up on a regular basis. They're great communicators. That is a huge component of coaching, is communication. And believe it or not, guess what the strongest skill is in being a great communicator? It's being a great listener. So many times it isn't what we say, but what we don't say and how we listen to our patients. They're also trust builders, so that this person may become, this coach may become the contact for a patient when maybe they would feel hesitant to call a doctor's office, they would call us as coaches. Again, we coordinate and target referrals, make sure that people go to those appointments. In some cases, coaches will go with them to appointments. It just depends on what you can do and what you have time to do. We can measure the outcomes of coaches. There are differences in health outcomes when you do population health coaching, and there are a lot of examples of those. And I think Joan's going to be talking about some of that from you know, her setting. And the skills are really transferable. Coaching skills are very applicable. They're applicable to your home life, your personal life, your professional life, and to even working in teams. So the two roles that coaches often play, care management, which is really looking at that best practice process, focusing on quality, closing care gaps, working within a team, being very patient-centered. And then the external piece of it, which can be more care coordination, in working in care delivery and partnerships and building the medical neighborhood and connecting the dots, which gets us back to the title of this whole conversation today, which is connecting the dots in the medical neighborhood and having the coach, you know, be able to do part of that work and introducing the role of the coach. Again, team-based care and decreasing fragmentation. One of the things, I don't know if any of you have experienced, is when you're contacting patients, do you ever hear the patient tell you that they've been contacted by 4 other people in the medical neighborhood and they aren't quite sure who's the right person to talk to anymore? So when we talk about decreasing fragmentation, it's also having a conversation back and forth in these different settings and finding out, is home health care calling them? Is the hospital calling them? Is primary care? And sometimes those patients will just shut down because they get to the point where they don't even know who they're talking about anymore. And realizing that when you get into coaching that, and Lori talked about this also, that this is a bigger picture than just medical care. In fact, if you look at these 2 circles, realizing that the factors that contribute to health and premature death are much more in terms of personal lifestyle choice and behavior change than it is medical care. That medical care slice is really very small, only about 10 to 20% of the influence. So I'm just going to close my part by just leaving you with the idea that we are in a new focus, population health, but we're in an era looking at all of the underutilized resources in healthcare and how to pull those resources together more effectively. And the greatest underutilized resource is the patient and the family themselves. So the role of the coach becomes that advocate and pulling in and engaging the patient and family so that they feel like they can navigate their healthcare environment.
Well, that's just great, gals. We appreciate you both. We are going to just do a quick spot check here with Joan and make sure, Joan, that you can hear us okay, and if we could get a sound check from you. Joan, can we just have you do a sound check with us? We cannot hear you.
We have unmuted you at this time. Joan?
Joan Parker.
Joan Parker, can you hear us okay? If you can you give us a little note? We cannot hear you, Joan. Joan Parker can hear us. And are you on the telephone then, Joan? I see your notes here that you had redialed. Okay. And we have unmuted you, so maybe we can just try to mute you again and then unmute. We'll see what happens with that. We're still working on getting audio with Joan, so if we can just have a couple moments, patience. Thank you.
we're not hearing you yet, so hang on just a second. We're going to look for you to see if we can see your name popping in.